Hi everyone, I'm Dr. Jeewat Ram. Today I'm going to discuss about ulcerative colitis. Outline contains introduction, epidemiology, pathophysiology, clinical features, management, investigation and treatment. Ulcerative colitis is a chronic inflammatory condition of the colon that is marked by remission and relapses. It is a form of inflammatory bowel disease. The annual incidence is 10.4 to 12 cases per lakh people, and the prevalence rate is 35 to 100 cases per lakh people in US. Ulcerative colitis is 3 times more common than Crohn's disease. It is more common in women than men. The age of onset follows a bimodal pattern, with a peak at 15 to 25 years and a similar one at 55 to 65 years. Although the disease can occur in people of any age. Etiology of ulcerative colitis. Exact cause of ulcerative colitis remains unclear. 3 characteristics that define the etiology: genetic susceptibility, immune dysregulation, altered response to gut microorganisms. Under physiologic conditions, homeostasis normally exists between the commensal gut flora, epithelial cells that line the interior of the intestines, and immune cells within the tissues. This homeostasis is disrupted in susceptible hosts by specific environmental and genetic factors, resulting in hyperactivation of T helper 1 and T helper 17 cells, increase in tight junction permeability, leading to uncontrolled chronic inflammation, that is ulcerative colitis. The rectum is always involved, with inflammation extending proximally in a confluent fashion. The disease typically is most severe distally and less severe proximally. According to extent of proximal involvement, it is classified into proctitis, proctosigmoiditis, left-sided colitis, extensive colitis, pancolitis. Inflammation is limited to the mucosal layer of the colon, except in fulminant disease where inflammation extends beyond the mucosal layer and can develop a toxic megacolon. Signs and symptoms of ulcerative colitis. Predominant symptoms are rectal bleeding with frequent stools and mucus discharge from the rectum, tenesmus, nausea and weight loss. In severe cases, purulent rectal discharge causes lower abdominal pain and severe dehydration. Constipation may be the main symptom when the inflammation is limited to the rectum. Proctitis. Although ulcerative colitis can present acutely, symptoms have usually been present for weeks or months. Signs of ulcerative colitis. Pallor may be evident. Rectal examination may disclose visible red blood. Signs of malnutrition. Severe abdominal tenderness, fever or tachycardia suggests fulminant disease. Grading of disease. Mild. Bleeding per rectum and less than 4 bowel motions per day. Moderate. Bleeding per rectum with greater than 4 to 6 bowel motions per day. Severe. Bleeding per rectum greater than 6 bowel motions per day in a systemic illness with hypoalbuminemia less than 30 grams per liter. Extraintestinal manifestations of ulcerative colitis. Ulcerative colitis is not restricted to GI tract, can involve almost any organ system. Up to 50% of patients can experience at least one extraintestinal manifestation. Ulcerative colitis is associated with various extracolonic manifestations, musculoskeletal conditions, peripheral or axial arthropathy, cutaneous conditions, erythema nodosum, pyoderma gangrenosum, ocular conditions, scleritis, episcleritis, uveitis, hepatobiliary conditions, PAC. Complications of ulcerative colitis: acute complications, toxic megacolon, potentially life-threatening complication, perforation, hemorrhage, chronic complications, cancer, extra-elementary manifestations, skin lesions, eye problems, and liver disease. Differential diagnosis of ulcerative colitis: other inflammatory bowel disease, Crohn's disease, infective, bacterial, Salmonella, Shigella, Campylobacter jejuni, tuberculosis, viral, herpes simplex virus, cytomegalovirus, protozoal, amoebiasis, non-infective, ischemic colitis, homogeneous colitis, NSAIDs, diverticulosis, radiation proctitis, Behçet's disease, colonic carcinoma. Diagnosis of ulcerative colitis: diagnosis relies on a combination of computable clinical features, endoscopic appearances, and histologic findings. Disease mimickers should be excluded. Laboratory studies: no single test allows the diagnosis of ulcerative colitis with acceptable sensitivity and specificity, useful principally for helping to exclude other diagnoses. Assess the patient's nutritional status. Complete blood count of ulcerative colitis shows leukocytosis, anemia, and thrombocytosis. CMP shows hypoalbuminemia, albumin less than 3.5 gram per deciliter, hypokalemia, potassium less than 3.5 milliequivalent per liter, hypomagnesemia, magnesium less than 1.5 milligram per deciliter. Elevated ALP suggests PSC usually greater than 3 times the upper limit of the reference range. Inflammatory markers: ESR and CRP correlates with disease activity. Other inflammatory markers, fecal calprotectin, can also be used to determine mucosal healing 3 to 6 months after treatment initiation. Fecal lactoferrin and alpha-1 antitrypsin studies are used to exclude intestinal inflammation. Stool assays used to exclude other causes and to rule out infectious enterocolitis. Tests include evaluation of fecal blood or leukocytes, ova and parasite studies, viral studies, culture for bacterial pathogens, Clostridium difficile titer, serologic studies, PNACA, associated serological marker, positive in 60 to 80% of patients, helpful in predicting disease activity, associated with an early need for surgery. Colonoscopy or sigmoidoscopy, essential at initial presentation to establish diagnosis, exclude alternate diagnosis like ischemic and infectious colitis, determine the extent and severity of disease. It may also be useful at the time of subsequent attacks to determine recurrence, for surveillance for dysplasia. Multiple biopsies could be taken. Biopsy of the terminal ileum should be attempted to exclude the presence of Crohn's disease. Gross findings include abnormal edematous mucosa with or without ulceration, extending continuously from the rectum to a part or all of the colon. Contact bleeding may also be observed, with mucus identified in the lumen of the bowel. Pseudopolyps in patients with long-standing disease. Histologic finding of ulcerative colitis: surface ulceration, inflammation confined to the mucosa with excess inflammatory cells in the lamina propria, loss of goblet cells, presence of crypt abscess. Imaging studies: plain abdominal X-ray, useful predominantly in patients with symptoms of severe or fulminant colitis. Images may show colonic dilatation with loss of haustral markings, suggesting toxic megacolon, evidence of perforation, obstruction, or ileus. Barium enema: it can be useful for detecting active ulcerative disease, polyps, or masses. The colon typically appears granular and shortened. CT scan shows loss of haustra, especially in the distal colon. Pseudopolyps, chronic cases, and narrow featureless shortened hosepipe colon. Approach considerations. The treatment of ulcerative colitis is made on the basis of disease stage, active remission, extent proctitis, distal colitis, left-sided colitis, pancolitis, and severity, mild, moderate, severe. Options: medical or surgical treatment. Treatment goals: induction of remission, maintenance of remission, prevention of complications, therapy-related allergies, intolerance, infections, lymphoma, steroid side effects, disease-related EIMAs, neoplasia, toxic megacolon. Medical treatment: aminosalicylates, the mainstay of therapy for mild to moderate ulcerative colitis. Preparations: sulfasalazine, mesalazine, effective at inducing and maintaining remission. Topical mesalazine given by suppository is a preferred therapy for disease confined to the rectum. Left-sided colonic disease is best treated with a combination of mesalazine suppository and an oral aminosalicylate. Corticosteroids used in acute treatment of moderate to severe colitis. Preparations: oral prednisolone, IV methylprednisolone, IV hydrocortisone, budesonide, and new glucocorticoid. Released entirely in the colon, has minimal to no systemic glucocorticoid side effects. The dose is 9 mg per day for 8 weeks and no taper is required. Rectally administered steroid enemas provide therapy for failures of distal ulcerative colitis. Thiopurines, effective for the maintenance of remission, not appropriate as solo induction agents for patients with severe disease due to their slow onset of action. Preparations: azathioprine 2 to 2.5 mg per kg per day, 6 mercaptopurine 1 to 1.5 mg per kg per day. Cyclosporine, used to treat hospitalized patients with severe ulcerative colitis. Dose is 2 to 4 mg per kg per day, given as a continuous infusion. Side effects: nephrotoxicity, opportunistic infections, seizures. Biologics, anti-TNF. It is an immunoglobulin G monoclonal antibody directed against TNF. It is a less toxic alternative to cyclosporine for patients with severe steroid refractory disease, effective for both induction and maintenance of remission. Preparations: infliximab, induction of remission 5 mg per kg IV 8 weeks 0 to 6, maintenance 5 mg per kg IV every 8 weeks. Surgical treatment: about 10% to 20% of patients with ulcerative colitis. Indications: chronic intractable disease, not controlled with medications or drug side effects are too severe. Severe acute colitis requiring an urgent procedure. Presence of dysplasia or cancer. Colonic perforation. Surgery: proctocolectomy, 2 options after proctocolectomy, permanent and ileostomy. J-pouch. Technically, proctocolectomy cures ulcerative colitis and prevents colon carcinoma.